Welcome to this presentation of DBS for dystonia. My name is Patrick Blomstedt and I'm Professor in Stereotactic Functional Neurosurgery at the University Hospital of Northern Sweden at the Unit for Deep Brain Stimulation. I and my colleague, Professor Marwan Haris, have experience from about 300 DBS procedures for dystonia. My intention is to here provide a brief overview for patients suffering from dystonia and who are interested in learning more about this therapy. You will here get the same information as at a consultation at our unit, but in a more detailed and pedagogic manner. I believe that by having a good understanding of your disease and about the therapy you're receiving, you will be in more control of your life, and that this will have beneficial effects both for your physical and mental well-being. However, I can of course here only provide you with general information without consideration to individual factors, and my opinions are based on our own experience and might not be shared by everyone. Before continuing with this presentation, please have a look at the previous video, What is Deep Brain Stimulation?, in order to be able to fully appreciate the details in the current presentation. Dystonia is a heterogeneous group of conditions of different etiology and character. It is a movement disorder characterized by involuntary, sustained or repetitive muscle contractions, often of a painful nature, resulting in twisting and repetitive movements or abnormal fixed postures. Sometimes it appears in isolation and sometimes in combination with other symptoms such as tremor. Due to the large variations, it is difficult to discuss DBS in general for dystonia, and I will here mainly limit the discussion to so-called primary dystonia, that is, dystonia which is not caused by cerebral paresis, trauma, anoxia, drugs or such. Dystonia is most often treated with medicine or Botox injections, and as long as these provide a good effect, other treatments are not indicated. However, if sufficient symptom relief cannot be achieved, then DBS might be considered. Dystonia is a consequence of pathological processes affecting the neuronal cells in the brain and changing their function. And since the neurons in the brain are connected in networks, a change in one area of the brain might affect the activity in other parts of the brain and give rise to a variety of symptoms. We looked in detail at how DBS works in the previous video, but basically, in dystonia, pathological neural impulses are propagated through nerve bundles through the whole brain and out to the peripheral nerves and muscles, where they will cause dystonic movements and postures. By implanting electrodes into the brain, we can introduce new impulses that will block the pathological signals and hence the symptoms. When the patient is referred to us for consideration of DBS, he or she will be evaluated by myself, our neurologist, DBS nurse, and neuropsychologist. The first thing we look at is the age of the patient. The brain is becoming more sensitive with age, and at some point the risk with surgery will be larger than the potential benefits. Opinions on how old is too old differs. We will not accept patients older than 80 years, but others are happy to perform DBS in older patients, and I don't know who is right. The DBS nurse will evaluate the patient according to various scales. These evaluations are documented on video, so we can always go back after surgery to see what we have achieved with DBS. Importantly, the DBS nurse will also discuss in detail the aims of the operation with the patient, and the patient will write these down. If you are considering to undergo DBS, then it is important that you define for yourself what you want to achieve and what degree of improvement that would make you satisfied, and what impact you would expect this to have on your life in general. It is important that your expectations are reasonable, and if I believe that we cannot meet the patient's expectations, then I will advise them not to have DBS. The neurologist will examine the patient, confirm the diagnosis, that the medical treatment has not been satisfying, and decide if further pharmacological treatments might be tested before DBS. The neuropsychologist will then evaluate the cognitive faculties. And finally, the neurosurgeon will make sure that there are no surgical contraindications, that the general health condition is acceptable, and that the patient has a reasonably healthy brain as seen on MRI. Further, we will discuss the details of the procedure and make sure that the patient has reasonable expectations. Basically, we will accept all patients who have symptoms likely to respond to DBS to such an extent that it will have a significant impact on their quality of life, that have reasonable expectations, and where there are no contraindications. In most patients who are deemed not suitable for DBS, this is not based on one single contraindication. The typical patient who I do not suggest DBS has some cognitive decline, an MRI demonstrating atrophy or vascular lesions, is close to the age limit for DBS, and often has some other issues regarding his or her general health condition. We will also discuss with the patient and decide on whether to use a rechargeable or non-rechargeable neuropacemaker. These have different advantages and disadvantages, and we will try to find what is most suited to the individual patient. I have discussed how the procedure is done in detail in the previous presentation. We perform the implantation with the patient asleep, based on the identification of the target structure in the brain, as seen on MRI, and the location of the electrode is verified with an intraoperative X-ray investigation. But, as I mentioned, there are many variations in how the procedure is done around the world. With few exceptions, we will insert 2 electrodes in a structure called the pallidum or the GPI. Concerning complications, stimulation-induced side effects, infections, hemorrhages, and hardware-related complications were discussed in the previous presentation. The GPI is a robust structure, and in our experience, surgery here is safe and has seldom resulted in any major complications or side effects. As I mentioned in the previous lecture, the patient will stay a few days after surgery and return after 4 weeks to start the stimulation, and then after 3, 6, and 12 months for further adjustments. It is necessary to gradually increase the stimulation strength in order to get an optimal effect. The effect will evolve over days, weeks, and months, but after 12 months, no further major improvements are expected. We will evaluate the patient each year or when needed, and the patient is equipped with a remote control, sometimes used for making minor changes in the stimulation. A rechargeable battery will last for up to 25 years and a non-rechargeable for about 4 to 5 years. And to change the battery is a minor procedure which is done in about 20 minutes with the patient awake or asleep. DBS is done in order to improve the quality of life of the patient, and after surgery the idea is that you should be able to forget that you have undergone this procedure. The implants will not break or change position if you fall or suffer a minor trauma, and you can virtually do whatever you want without taking the DBS into consideration. We are making our patients better with DBS, but to some extent this is a potential improvement that needs to be realized. Many patients with dystonia need to learn again how to use their body in a more normal manner. Therefore, we will send these patients for 3 weeks of rehabilitation, and this is done 6 months after the procedure, when we expect to have a good effect from the DBS. Concerning the outcome, patients with secondary dystonia after trauma, cerebral paresis, and such will usually not have as good an effect of DBS as those with primary dystonia. Often, In these patients, other symptoms are present, such as paresis, spasticity, ataxia, and such, on which DBS will have no positive effects. And it can be challenging to decide exactly what is dystonia and how DBS might improve the quality of life in such patients. So in these patients, a thorough evaluation by an experienced neurologist is necessary. But some patients with secondary dystonia will have a good effect of DBS. Regarding the outcome in primary dystonia, I consider that we have a good outcome in about 90% of the patients. But it is important to remember that DBS does not cure. It is only hiding some of the symptoms. Typically, we will reduce the patient's symptoms with about 70%. And the effect of DBS is, as mentioned, not immediate, but will develop over weeks and months. I believe that about 90% of our patients are satisfied with the procedure. Some of them are very happy, while others are satisfied even if they had hoped for a better effect. The effect is, in our experience, stable over time, and DBS will, even when successful, not remove all symptoms, so it is important to have reasonable expectations. And in order to realize the full potential of DBS, you need to be willing to commit to training and rehabilitation after surgery. In about 10% of the patients, we will not achieve a satisfying result, and unfortunately we cannot decide before surgery if DBS will be successful or not in the individual patient. It can be difficult to describe the results in words, so let us look at 4 of my patients in order to get a better understanding of what we can usually expect from DBS. Let us start with the case of blepharospasm, that is dystonia with difficulties of opening and keeping the eyes open. I apologize for the poor quality of this video. The patient is in this video attempting to open the eyes, but was unable to do so without using his fingers. And here to the right, we see the same patient after surgery. He has now no further problems from the eyes. Here we have a case with dystonia of the tongue. He was unable to speak since 2 years and had to feed himself with a syringe. And to the right we see him 6 weeks after surgery, when he has regained his speech.
Opererat mig i hjärnan, i munnen, för att jag inte kan prata på 2 år. Men nu går det bra som helst att prata efter operation.
Here we have a man with torticollis, that is dystonia in the neck, before and after surgery. I should also mention that dystonia is often painful, and often the first and most appreciated effect of DBS is the pain reduction. In the video to the right, the patient is demonstrating how he can now after surgery move the head without twitching and shaking. Finally, I would like to show you a case of generalized dystonia affecting the whole body. The patient was before surgery moving constantly, had a poor gait and very poor fine motor skills. After surgery, he has no involuntary movements, his gait is much improved, and his fine motor skills are excellent. And with that, I end this presentation. I hope that you have found the information to be of some value. Thank you for your attention.